So Jean Peretti and I, Jean's one of our nurses with the Geri HRSA team. We're going to be talking about drugs and deprescribing, and we're talking about all the potentially inappropriate medications. So anticholinergics, antipsychotics, and benzos. Oh my, kind of like lions, tigers, and bears. But I always introduce and describe myself as the pharmacist that doesn't like medications. And it's because, as we saw in the previous video, there's a lot of concerns and a lot of risks that come along with medications in our older adults. And it's hard conversations to have based on our current health culture, because our health care culture tells us how to treat, but it doesn't tell us how to take away medications safely. So I'm hoping to help you do that today. So when you hear the word geriatrics and medications, if you just want to type into the chat box, what do you hear, or what do you think of when you think of these two words? Scary. Too many, specialized, at risk. Yes. Side effects. All of these things. Absolutely. So I think of polypharmacy. Our older adults with more chronic conditions are at more risk of prescribing medications for those chronic conditions, which then leads to a prescribing cascade. If we're treating medication side effects with other medications, it all builds up. And it leads to pill burden. And I saw someone type in opportunities, and absolutely, there's plenty of opportunities for deprescribing. And we can use different tools like the Beers criteria, lists for potentially inappropriate medications to help us. So there's lots of different tools that we can use. We can identify if they're anticholinergic, like Alice in our previous video, her medication was strongly anticholinergic. We can determine if they're sedating, what those risks are, and how they impact our older adults, especially if they're frail older adults. We can look at them to make sure that we're identifying if they're at fall risk medication or if they're deliriogenic inducing. But we can identify all of these, but on top of all of it, there's really limited evidence. Our older adults weren't up until most recently prioritized to include in clinical trials. Up until 2019, older adults weren't mandated to be in clinical trials based on age. The NIH in 2019 did a mandate to include all ages of patients in clinical trials to eliminate ageism in our randomized controlled trials. But up until most recently, we don't have a lot of evidence for older adults. And so today we're going to define what polypharmacy and what potentially inappropriate medications are. We're going to list some resources to identify those medications. I'll talk about at least three different medications that you can identify using the Beers criteria and what the most recent update of that looks like. And then finally, we're going to talk about how to evaluate medications for appropriateness and patient-specific factors that you can use when you're talking about deprescribing in older adults. So the video talked about everything that I'm about to talk about right now, but we have older adults with multimorbidity or multiple chronic conditions that lead to more medications. There's increased risk of side effects from these medications, increased risk of drug interactions that can then lead to other effects, and we have a prescribing cascade treating some of those side effects potentially. And so all of that leads to polypharmacy and medication burden, and on top of that, potentially inappropriate medications. So we'll talk about the different potentially inappropriate medication resources. But when I'm thinking about medications as a pharmacist, I think about medications in terms of the 4 M's, which I know you've previously talked about with the 4M and age-friendly healthcare framework. So when I think about medications, I want to make sure that if we have to use medications, that they're age-friendly and they're not interfering with any of the 3 other M's. So they allow our older adults to mobilize as they normally would or enhance their mobility. They do not cause any harm to their mentation, so they're not causing any kind of cognitive impairment, they're not causing delirium, and they allow our older adults to do what matters most to them. So potentially inappropriate, I'm going to refer to them likely as PIMS going throughout, but PIMS is potentially inappropriate medication. So the key thing here is it's potentially, not definitely, inappropriate. There are plenty of medications that that you will identify on the Beers list or other criteria that, if we don't have any other options, they are safe, or not safe, but they are appropriate to use in older adults. And so we just have to make sure we're using them in the safest way possible, knowing the risks and the side effects that may emerge and how we can appropriately manage going forward. And it's these resources that I'll share with you, they're just a warning light to identify medications that have an unfavorable balance of risks and benefits in older adults. So it's not a stoplight, it's just a warning light that maybe we should reevaluate, maybe we need to look at this and make sure that all of the benefits are outweighing the risks if we're going to have to use this medication. So there's different resources that you can use. The Beers criteria and the start and stop criteria are two of the biggest ones. I'm going to go through the Beers criteria shortly, but the start and stop criteria, the start means screening tool to alert to the right treatment. So it's helping us identify the potential for under-treating patients. And then STOP is screening tool of older people's prescriptions. There's various forms of this STOP criteria. There's one towards at end of life and one with frailty. But a lot of the medications on these lists are reflective of what's in the Beers criteria. So I'm only going to talk about the Beers criteria today. So the Beers criteria, it started back in the early 90s, but it was most recently updated with the American Geriatric Society in 2019. And it is for use across all settings, institutional, outpatient, acute care, except for palliative and hospice care, because some of the medications used for comfort or for symptom management are on the Beers criteria, and they should not be withheld during palliative or hospice care for comfort or symptom management. What's great about the Beers criteria is it's just not the tables. They have other helpful resources if you go through the American Geriatric Society website. So they have a paper called Using Wisely, which is a paper that's written for everyone. It's written for healthcare providers, for patients, for caregivers, on what the Beers criteria actually is and how it is just a warning light. It's not a stoplight. And then they also have alternatives tables. So they have all of the resources that they use to determine why these medications are on the Beers criteria, and then they have helpful alternatives that you can turn to and the resources that support them as well. So I'm going to walk quickly through the tables because the Beers criteria is not just one table, it's actually 7, and they all have their own useful purpose. One is just the quality of evidence and strength of recommendations. I wouldn't say it's the most useful table, but it is important to know. And number 2 is the table that we typically tend to think of as the Beers criteria. It's the big table that for medications that are potentially inappropriate in most older adults. So this applies to 65 years or older. It can apply to all patients and all people within that above that age range. So this is where you'll find things like antipsychotics, tricyclic antidepressants, benzodiazepines, NSAIDs, skeletal muscle relaxants. And so it's organized by organ system and disease state, and you can find a lot of different medications and the rationale in that table. The third table is drug disease or drug syndrome interactions that are specific to older adults. So this would be anticholinergics and delirium, antipsychotics and Parkinson's disease, or NSAIDs with CKD stage 4 or higher. So this is a shorter table, but it's specifically for those interactions that we find more commonly in older adults. Drugs to be used with caution means that these drugs have been identified as potentially inappropriate, but we can't apply them to all 65 years or older patients. So it may be a specific age range threshold that's a little bit higher than 65 years or older. So one example would be aspirin for primary prevention. We can apply it to 70 years or older to reevaluate, but we can't apply it to all older adults. Drug-drug interactions is in table 5. So this is where you see things like opioids and benzos. The combination together in older adults is an increased CNS sedating medications. Same with duplicate anticholinergics for burden. And opioids and gabapentinoids is another one that's listed in this table. Table 6 lists some ones that we need to think about with impaired renal function. This is not an end-all be-all list of medications that we need to dose adjust in renal impairment, but it does have some specific ones that we need to think about where the buildup or the accumulation of the medication could be potentially harmful in older adults. One example would be duloxetine, famotidine, because of some anticholinergic properties are listed on here. And then finally, there is an anticholinergic burden table that lists the different anticholinergic meds. There are other resources too, the anticholinergic burden scale that you can refer to, and so they're good to cross-reference, and this is just a quick list that you can access easily. On here, we have some TCAs, paroxetine, like Dr. Ng mentioned earlier, is highly anticholinergic, oxybutynin, and some other commonly anticholinergic meds. So that was a really quick overview. We know what PEMs are. What do we do with them? This is how we talk about deprescribing, and this is when we start to assess that. So the actual definition of deprescribing is it's a systematic process of reducing or stopping medications that may be harmful or no longer needed in patients. And what I want to draw your attention to is the keyword systematic process. So this is actually, we take steps for deprescribing. It's not just holding medications while they're in the hospital. It's not just stopping everything. There's multiple components to it. And here is, there was a systematic review that looked at deprescribing practices across the country. And they found that these are the 5 key components of successful deprescribing practices. The first one is comprehensive medication history. So we can't successfully deprescribe if we don't know what the patients are actually taking. And so this is the first key point, is figuring out what medications the patient are taking and using multiple resources to obtain this information. So in Team Alice's webinar, they had records of cyclobenzapine, but had they asked the daughter or the patient, was she actually taking it? Who manages the medications? How does she take them? That might have all been avoided. After we figure out what medications the patients are taking at home and how they're taking them, we can then identify potentially inappropriate medications using those resources that I just talked about. Another resource that we can use to identify the medications is the Medication Appropriateness Index, which is a tool of 10 questions that you can use to identify the indications for medications and how safe they may be in patients. If you search it, there's a lot of papers describing it. We're also going to talk about the third step, which is determining if the medication can be ceased and prioritized. And we'll talk about that later in the presentation. But so once we've determined what the potentially inappropriate med is, we're going to start to talk about it with our patients. And then we've got shared decision making and everybody's engaged. Then we're going to start to decide how to stop the medication. So we're going to plan and initiate withdrawal. And we'll determine if it needs tapering or if it can be stopped safely without tapering. And then finally, support and documentation are the key. So supporting our patients, their caregivers, their family members through this process is huge. And also documentation of this is huge as well. So it's not just you participating in the deprescribing process, it's everyone who's involved in the patient care is participating. We're going to move back to determine if medications can be ceased and prioritized with some resources at the end of the presentation. But another way that we can do this to identify if medications are inappropriate is thinking about it in terms of time to benefit and time to harm of the medications. So what this looks like is this is my favorite chart of all time. I'm sure some people on this call have seen this before from me, but we want to think about medication appropriateness in terms of the patient's goals of care, our treatment targets, and how long it will take for a medication to show any benefit and how long it will take to show harm. So we never want our pyramid to be misaligned. We want our treatment targets, our time to benefit, and our goals of care to consistently align. And if it's misaligned, then we have opportunities for deprescribing. I say the word time to benefit and time to harm Time to benefit is the idea that a clinically relevant benefit, or if we're talking about harm, a clinically relevant harm will emerge within the patient's life expectancy. So shorter onset medications, like symptom relief medications, have a short time to benefit. Medications for primary, secondary prevention have a longer time to benefit. Unfortunately, we don't have trials that went out and said, how long does it take to show a benefit? We don't, that's our whole goal. We just want to know how long it takes to show benefit of statins. But we can derive the time to benefit and time to harm from the trials that we do have that included older adults, and look at the duration of the trial and the outcomes that emerged within the trial. So I'm going to quickly show you a table with statin time to benefit and time to harm. You don't have to read the whole thing. I just want to demonstrate the impact of what we're looking at within the trials, and these will be available later for you to see and to look at the current trials that we have. So this is for statins. These are 4 of the big trials that included older adults. And I included a bunch of things like what statin was used and what population was studied in this trial. But what we're using here is how long the trial lasted, so the duration of the trial and follow-up that emerged, the conclusions and the outcomes that came from those trials, and then the adverse events or the events that came during the trials as well. And we can use all 3 of these concepts to determine the time to benefit and time to harm for different medication classes. And I'm going to pass the ball to Jenny here, or to Jean here, and she's going to talk about barriers.
Sorry, thank you. I just quickly wanted to add that this is the pocket guide, the Bears Pocket Guide. It's long, but if anyone wants a copy, you can reach out to me or to Becky, and we can get this out to you. They're kind of candy to have. That being said, there are barriers to deprescribing. There was a study done in 2017 called Swimming Against the Tide, Primary Care Physicians' Views Against Deprescribing in Everyday Practice. So we're going to just go quickly through the barriers identified. There's certain expectations from the patient. For example, when Alice went into the emergency department, she wanted something to help her relieve her pain. So providers feel obligated to meet the expectation and actually add a medication rather than taking something away. There's also relationships that are barriers, especially provider to provider. Newer and experienced providers may not understand and don't know why an older, more experienced provider may have added a medication, so they're slow to take away. Culture is huge. It's a cultural barrier, social, healthcare, culture, guidelines, and education. Like Megan was saying, guidelines, there's a lot more guidelines about indications when to add versus when to take away. And education is key. Organizational barriers, fragmentation of care, communication, and time. EMRs, different practices have different EMRs, and time, as we all know, is a luxury. It's hard to dig through charts, communicate with people to find out why a medication should be stopped. And fear. Providers were nervous about deprescribing for lack of concern about their reputation, perhaps taking a medication away and having an adverse outcome. These are just some quotes about deprescribing. It's easier to add a medication. Again, it's a time factor rather than looking to see what they can take away. Guidelines, someone recently diagnosed with type 2 diabetes is going to be given anti-diabetic along with an ACE inhibitor to protect the kidneys. There's 2 medications added for one chronic disease, probably more. And again, it's what's taught. There's very little education, I should say, regarding deprescribing. It's all about adding medications and helping. Fragmentation of care. Newer providers are just meeting people for the first time, so they're hesitant to just go right in immediately and remove medications. They need to know who the patient is and get more information. And especially for primary care providers, a specialist may have added a medication and they just don't know why it was added. They're reluctant to just take it away. They need to communicate and find out. And again, it's time and communication. The barrier of fear. Doctors don't want to be perceived as being incompetent or taking medications away, and then someone having an adverse event. And providers were concerned that they may be perceived by their patients as someone who doesn't care. So they're saying, hey, you're old enough to die, so who cares if you take this medication away? Beneficence, we're all geared toward doing the right thing. We don't want to harm our patients. And we all want to do what's right for the patient regardless. And again, there's that time to dig in the chart and find out and talk to other doctors to find out if it's okay to remove that medication. So obviously there's big barriers. Here they all are listed, and education is key. One of the biggest outcomes or findings of the study was that not is it only important for the provider to change their attitude and behaviors, but it's also important for a patient to understand they may not really want a new medication, although they ask for it. So it's a lot of communication and a lot of education on our part to tell people why something may be deprescribed. And lastly, so I do home visits, and this is actually a picture of someone's home and how they manage their medications. So everyone has their own system, right? So, and sometimes they work and sometimes they don't, but you can see how easily someone can mess things up. People even keep their old medications in case they need them for the future. There's expired medications. So when someone goes into the office and presents their medications, it may look very pretty, but just know when they go home, it may look like this. So it's important that we stay on top and try to reduce the amount of medications that they actually are taking. So short and sweet. Back to you, Megan.
All right. Yeah, so there's a lot of barriers that Jean described to deprescribing, but there are some tools out there in addition to the Beers criteria that can help you safely deprescribe. I'm going to speak about deprescribing.org, but I want to bring your attention back to the video that I showed earlier. The U.S. Research Network for Deprescribing is relatively new, but they are pushing out a lot of research and a lot of webinars and resources. So I'd encourage you to go to that website and explore it. They have some fantastic resources there. Deprescribing.org is actually part of the Canadian Deprescribing Research Network. This was developed by a team of physicians and pharmacists out of Canada, and they went to the evidence and a panel of experts to develop evidence-based recommendations and algorithms for deprescribing. So it's deprescribing.org. That is the name of the website. It is what it is. And I'd encourage you to play around with it, but know that there's also an app available too. I would start with the website first. But what it is it has evidence-based recommendations for patients and conditions that are eligible for deprescribing. It has tapering regimens for eligible medications, and then management and monitoring parameters for how we can deprescribe. It also has counseling points for patients, and it has a lot of patient empowerment tools too. So there's educational pamphlets, education about why medications may no longer be beneficial or why they may be causing harm, that self-empower patients to talk about deprescribing, and to give them language and terms that they can use to ask questions about their medications with their healthcare providers. Some of the key things that they have are the algorithms for 5 different classes of medications, and they're always adding medications classes, so just refreshing and see if there's anything new. They have benzodiazepines and Z drugs, so Z drugs are like zolpidem, azapiclone, zaloplan, antipsychotics, proton pump inhibitors, anti-hyperglycemic agents, and then medications for dementia, so cholinesterase inhibitors and memantine. I'm going to show you just the algorithms for benzodiazepines used for insomnia, but they're very similar for all of the classes of medications. So if you're clicking on a class of medications, it will come with some educational videos. It comes with the actual evidence-based guideline, which is the giant document that walks through the evidence for how they developed these algorithms. And then it has the front and back page PDF of the algorithm that's really easy to use. And that is what is in the app as well, is the algorithm. So this is the front page of the benzodiazepine algorithm for deprescribing. It walks you through what the patient is taking the benzodiazepine for, if this is an indication that you can use for deprescribing. I'm not going to walk through all of these points, but I'd encourage you to take a look at them. They're really easy to use. Once you determine if this is a medication you can safely deprescribe, it gives you how to deprescribe. So it gives you dosage recommendations and percent reductions each week. And then finally, it gives you monitoring parameters for how long to taper these medications and what to do if withdrawal symptoms reemerge. On the back page of the algorithm, it also lists all of the dosage forms of the medications that you could potentially be working with. So then you know how to dose reduce. And it also gives you education pearls for your patients so they know what to watch for when you're doing the taper. This is how you access them on the website under resources and then guidelines and algorithms. It's really easy to use and quite user-friendly. And then this is what the app looks like. I have an Android, so it looks like this on my phone. It may look a little different on iPhones. So this is what we hope to achieve today. We talked about polypharmacy and potentially inappropriate medications. We talked about the Beers criteria recent update, and then finally some resources and tools for deprescribing. Thank you all.